right. Good evening, everyone, and welcome to this webinar in collaboration between South African Society of Maxillofacial and Oral Surgeons and South African Dental Association. Our topic tonight is the medication-related osteonecrosis of the jaws. A few admin-related announcements before we start. Please refrain from using the raise hand button, but type your comments and questions in the Q&A tab. CPD certificates will be loaded to the SADA platform, and you will be able to access all your certificates under your member profile. If you are not a SADA member, you will be able to create a profile for yourself and access the CPD certificates. The event for tonight qualifies for one clinical CEU point. We are streaming live on YouTube also, just in case you have difficulty to access the Zoom platform. After the countdown is... I am your host tonight, and I'm Dr. Hira. Dr. Metsing has taken ill and won't be able to be hosting tonight. In just a few short moments, I'm going to hand over to our presenter, a few more announcements. Future upcoming webinars, please be aware that we have another webinar scheduled on the 20th of October by Dr. Ridwan Hafiji. The next will be on the 22nd of September, Henry Shine Evening with international speaker Dr. Tara Mukhanan. On the 22nd of October, we have one in collaboration with CESPIO by Dr. Fahim Bamji. And the next one will be on the 29th of October, which is again a Henry Shine Evening with international speaker Dr. James Robson. Without any further delay, I'd like to hand over to my co-host, Dr. Boris Vali, also a maxillofacial surgeon and a colleague, as well as someone who taught me, to introduce our speaker, Professor Rikhotso. Dr. Boris Vali, over to you.
Good evening, everyone, and thank you very much, Dr. Hira, for the very kind introduction. It is my honor and privilege this evening to introduce our speaker for this combined SASMOS SADA webinar collaboration. My friend and colleague, Professor Ephraim Rikhotso, who is the head of the Department of Maxillofacial and Oral Surgery at Wits University. Ephraim sits on the executive of the Maxillofacial Society and for his sins. However, he obtained his undergraduate degree from the University of Witwatersrand in 1993 and worked as a general dentist at the Soweto Oral Health Service for a year before going into private practice. In 1999, he commenced his registrarship in MFOS at Wits and completed in 2002, obtaining both the master's and the fellowship of the College of Medicine. To my great delight, he completed his master's and PhD. Well done, Professor Rikhotso, on a great study from Wits University, and he is the current head of department at Wits University. So without any delay, I'm going to ask Professor Rikhotso to share his knowledge on bisphosphonates with our profession. Ephraim, the floor is yours.
Thank you so much, Dr. Boisvali, for the introduction. I'm honored to represent our society, SESM-FOS. I want to take this opportunity to thank SADA for their collaboration with our society. As has been indicated earlier on, our topic that we're going to share together tonight is MRONJ, which is medication-related osteonecrosis of the jaws. Perhaps before I start, since I'm representing SESM-FOS, it is maybe proper to give credit and honor to the giants in the field of maxillofacial surgery who have developed and continue to grow maxillofacial as a specialty in South Africa. So as Isaac Isaac Newton said, if I've seen any feather, it is by standing on the shoulders of giants. So I give honor and credit to all the giants in the field of maxillofacial and oral surgery. Secondly, I wanna doff my hat to all the COVID frontline workers, especially our colleagues that have departed. Thank you so much. Whether you were infected or affected by the pandemic, as frontline workers, we should be proud of ourselves, of what we have done and what we are continuing to do. So thank you very much. Now, I have nothing to declare except that I support Kaizer Chiefs and Manchester United. Now, in 2019 BC, that is before COVID, both teams were doing remarkably well. So we can extrapolate from this data that COVID has had a significant impact on the performance of these teams. And we hope very soon COVID will be a thing of the past and we'll get back to winning ways. As an outline of our discussion tonight on MRONJ, so we'll do a bit of review of bone remodeling, and we talk about some of the purported pathogenesis of MRONJ, epidemiology and the staging, and we look at a few case reports, management and preventing strategies and complications. Now, it is not uncommon for us in the field of dentistry to be confronted with conditions of exposed bone as shown in these two pictures. What is important when you are confronted with these cases is to take a very good medical history and obviously followed by examination. And those two are imperative for accurate diagnosis. And it's important for us to know what the diagnosis is, because that diagnosis guides the treatment goals and also the methods that we're going to use to treat those conditions. So it's almost careless, bordering on negligence, if you fail to obtain adequate history from the patient. So never ignore what the patient has to tell you, because that's what's going to guide the ultimate diagnosis. So in these conditions of exposed bone intraorally, your differential diagnosis could be osteonecrosis of the jaws, MRONJ, that's what we're talking about today. Could be osteomyelitis or osteopetrosis or even osteoradionecrosis, what other people call the 4 O's. But your ultimate diagnosis will be dependent on thorough medical history that you're going to take. So as a way of starting, let's go back to the physiology of bone remodeling, because I think it's critical to understand what would be the pathogenesis of some of the conditions that we're going to talk about tonight. So as you will recall from our undergrad studies, the bone remodeling is dependent on these two cells, your osteoblasts and your osteoclasts. So your osteoblasts, they lay down the bone, whereas your osteoclasts are the cells that are involved in the resorption process. So your osteoblasts will lay down your osteoid, which is going to consolidate into mature woven bone, and your osteoclast will do the bone resorption. So that process of osteoblasts laying down the bone and osteoclast resorbing the bone, it's called a coupling process. So you could think about osteoblast and osteoclast as a couple. So if I were to genderize them, I will say the osteoblast is the female because that's the production, that's the side of production. That's why we call them secretory osteoblasts. And your osteoclasts are going to resorb the bone. So that will be what I would call the destructive male. So osteoblast laying down of bone, osteoclast resorption of bone. Now, to understand the function of the osteoclast in terms of what determines the differentiation, maturation, and function of osteoclast, there are three proteinaceous structures that we need to know. One is called the rankle, the other one is rank, and the other one is OPG. So these three tumor necrosis factor-like proteins are critical in the bone remodeling process. So let's look at this illustration that we tried to do. So assuming that's your osteoblast and that's your osteoclast. So your osteoblast, it's responsible for laying down of bone, and your osteoclast responsible for bone resorption. But as I say, there are these three tumor necrosis factors that play a critical role in osteoclastogenesis through what we call a protein kinase system. So your osteoblast is going to secrete your rankle and also your OPG. Now, your rankle is going to bind to rank receptors on the osteoclast precursors or the osteoclasts themselves. The binding of rankle to osteoclast precursors is going to stimulate differentiation, activation, and survival of your osteoclast. And only then will the osteoclast be able to resorb your bone. So in essence, your osteoclast controls this osteoclastogenesis process because they secrete the rankle and also OPG. Rankle binds to rank receptors. Now your OPG acts as a decoy rank receptor. So if your OPG binds to rankle, it's going to stop the differentiation, activation, and survival of your osteoclast. So therefore, you're not going to get any bone resorption. So OPG, rankle, and rank, these are the three structures that we need to add. So your rankle, as I said, from osteoblast. Your OPG, again, from osteoblast. So that's a decoy rank receptor. So if OPG binds to rankle, there will be no bone resorption. Whereas if your rankle binds to rank receptors on the osteoclast or osteoclast precursors, you're going to end up with bone resorption. So your osteoblast is the controlling cell in this process of osteoclastogenesis. Now, another illustration of that process that I was talking about. So there are your osteoblasts, So they lay down the bone. As I said, they secrete your rankle and your OPG. The rankle will control the differentiation and maturation of your osteoclast, which then will be able to be activated and resorb the bone. So as I said, if I were to genderize them, the osteoblasts will be the females and your osteoclasts will be the male. So these are secretory osteoblasts. As you can see, they are much smaller, good looking, hence describing them as females. And your osteoclasts are big, unsightly like some males that I know, but they do the function, which is resorption of bone. The other thing that we need to understand is that when you end up with metastasis into bone of your cancer cells, your tumor cells, there are two processes involved. One is your osteolytic process, and the other one is your osteoblastic process. So the cancer cells themselves are able to produce their own rankle, and that will activate the osteoclast, as you can see here, which will start the bone resorption process. Okay, so the cancer cells are able to produce their own rankle, and that can cause resorption of bone, and that will allow the cancer cells to spread into the bone. And the other process is that when your cancer cells are able to produce growth factors, which are able to stimulate osteoblastic differentiation, and that will result in laying down of immature woven bone, and that's the kind of bone that you'll pick up on bone scans. So you can either have an osteolytic or an osteoblastic process when you end up with metastasis of bone. Now, some conditions such as multiple myeloma, it's only an osteolytic process, and that's why you end up with punched out lesions in the bone. And those conditions, if it's only osteolytic, you're not going to be able to pick that up on bone scans. Now, what are some of the factors that prevent or inhibit the resorption of bone? One is calcitonin, your bisphosphonates, your anti-angiogenic drugs, and also your denosumab. Now, denosumab is a human monoclonal antibody to your rankle. So it's going to prevent your rankle from binding onto your rank receptors. So in that way, it's going to prevent your differentiation, maturation, and activation of your osteoclast. So with that background in mind, in terms of the whole bone remodeling process, what is MRONJ? Now, MRONJ was first described in 2003 by Robert Marks. And the criteria for diagnosis of MRONJ, one is exposed or necrotic bone of a period greater than 8 weeks. Now, the European Advisory Committee on MRONJ of lately are starting to question this waiting period of greater than 8 weeks. The current thinking is that early diagnosis will lead to better control of the disease. So the 8 weeks period may no longer be necessary for the diagnosis of MRONJ. The other criteria is history of previous use of either bisphosphonates, other antiresorptive medications, or antiangiogenesis. And there should be no history of either radiotherapy or obvious malignancy of the jaws. Initially, this condition was described as MRONJ because it was thought that it was exclusively associated with bisphosphonates. But as we know now, it's not only bisphosphonates that will lead to osteonecrosis of the jaws. In terms of the epidemiology of MRONJ, oral bisphosphonates have been reported in the literature to have a frequency of 0.01 to 0.1, whereas IV bisphosphonates much higher incidence. Now, a combination of bisphosphonates and antiangiogenesis increases the risk of developing MRONJ to about 16%. So, because the incidence of MRONJ is much low in patients taking oral bisphosphonates, it kind of poses a significant challenge for future clinical trials aimed at establishing accurate incidence data. So the paucity of the cases associated with oral bisphosphonates makes it very difficult to have concrete evidence about the prevalence of MRONJ in this patient. So how do this patient, what are the common sites of involvement of MRONJ? Obviously, your alveolar bone, your mylohyoid ridge, and in areas where you have thorax, and the mandible is commonly affected than the maxilla, and females are also affected more than females. What is interesting about MRONJ is the fact that it only affects the jaw bones. So even though your bisphosphonates or antiangiogenics have systemic effects, none of them are affected by MRONJ. Only your jaw bones that are affected by this condition. And as we go along, we'll look at some of the reasons that may be responsible for that. So what are the purported pathogenesis of MRONJ? So medically related osteonecrosis of the jaws. So one theory that has been proposed is that there's disruption of your normal bone turnover cycle. So the bone remodeling that we're speaking about earlier on, this disruption of that bone remodeling process by medications called antiresorptive medication. It is also toxicity of the mucosa, the presence of inflammation. There could be some genetic predisposition, but also suppression of your immune response. So that these are the factors that may be responsible for development of MRONJ. So in terms of your inhibition of bone remodeling process, so if, for example, there's disruption in the functioning of your rankle or the ability of your osteoclast to attach onto the bone to initiate the remodeling process. So that is going to disrupt the whole bone remodeling process. In terms of your antiresorptive medication, we talk about two types. One, your bisphosphonates. So the bisphosphonates inhibit osteoclastic function. And two is your denosumab. Then that's a monoclonal antibody to your rankle, as we said. So your denosumab is an antibody to your rankle, so it's going to prevent the binding of your rankle onto the rank receptors. Whereas your bisphosphonates will affect the function of osteoclasts in the bone resorption process. Okay? the half-life of bisphosphonates reported to be 10 to 12 years, and some people say even maybe to infinity. Whereas the half-life of denosumab is 25.4. So what are these bisphosphonates that we're talking about? Bisphosphonates are synthetic analogs of naturally occurring pyrophosphates. And that's a structure of naturally occurring pyrophosphates. Now, they have been used in terms of prevention of ectopic calcification. But what was found was that when they were given orally, they were inactivated by this enzyme phosphatase. To prevent that inactivation of this pyrophosphate, this oxygen at the center was replaced by carbon, and to the carbon was attached two molecules, what we call the R1 or H1 and R2. And this structure constitutes your bisphosphonates. So your R1 determines the ability of bisphosphonates to attach onto bond, affinity of bisphosphonates to bond. And your R2 determins the potency of bisphosphonates. So there are two kinds of bisphosphonates, nitrogen-containing bisphosphonates and non-nitrogen containing bisphosphonates. And you also have them delineated into oral bisphosphonates and IV bisphosphonates. What we know as of today is that your nitrogen containing bisphosphonates are much more potent compared to your non-nitrogen containing bisphosphonates. And also your IV bisphosphonates much more potent than your oral bisphosphonates. So generally, bisphosphonates are used in cancer-related diseases, such as hypercalcemia of malignancy. They are used to prevent bone metastasis, for example, from breast and prostate CAs and multiple myelomas. They're also used in the treatment of osteoporosis and osteogenesis imperfecta. Mostly your oral bisphosphonates are used in the treatment of osteoporosis, and your IV bisphosphonates for malignant conditions. So bisphosphonates, as I said, they act by preventing your attachment of osteoclasts to the bone surface, which basically prevent or stops the resorption process and promotes early death of your osteoclast. And the thinking is that they inhibit this enzyme's farnesyl pyrophosphate synthase. And that's the enzymes that's responsible for attachment of your osteoclast onto your bone surface. So maybe just to make a comment as we go along that whilst bisphosphonates impair or kill your osteoclast, osteopetrosis is a condition caused by genetic impairment or loss of your osteoclast. But in terms of the clinical manifestation, these two may show the same manifestation in terms of exposed bone, pain sometimes. So these two conditions all involve some kind of impairment to your osteoclast. And osteopetrosis is a genetic problem, whereas in MRONJ, as we know it, there's impairment or killing of your osteoclast. Another pathogenic mechanism, it's thought to be inflammation and infection, that it may increase the risk of development of osteonecrosis. And I'll come back to this later. a study by Risto in 2018 has suggested that because of the high prevalence of infection in the oral cavity and subsequent acidic pH environment, that acidic pH environment may increase the release of your bisphosphonate from bone. So essentially, your bisphosphonates kind of get stored in the bone matrix or within the osteoclasts themselves. But the presence of an acidic environment, as we see in sepsis intraorally or periimplanttitis or periodontal disease, that acidic environment on its own is able to stimulate the release of your bisphosphonates stored in the bone matrix, and that will result in MRONJ as we know it. And the other theory is your antiangiogenesis, which basically compromises blood supply. Obviously, without adequate blood supply, your healing capability is decreased. These are some of the antiangiogenic drugs that are used. Another theory is that bisphosphonates have a direct toxicity on the soft tissues. As a result, post-trauma, which could be in the form of extraction of periodontal disease or surgery, your soft tissues are unable to heal properly because of the toxicity that is exerted on them by your bisphosphonate. So this study by Landsberg has shown that, or suggests that your bisphosphonates inhibit your oral keratinocytes, which obviously impair the healing process and may play a significant role in the initiation of osteonecrosis of the jaw. And obviously, if you are immunocompromised or on long-term steroids, the risk of development of MRONJ is also increased. Of patients who develop MRONJ, but that's also not established. It's just a suggestion that is there in the literature. So, what is the staging of MRONJ, of this exposed bone that we have in the mouth? So, the recent staging of MRONJ suggests that there are 5 stages of this disease. There are patients that are described to be at risk. So these are the patients that have no apparent necrotic bone, but these patients have been treated using either oral or IV bisphosphonates. So those are described to be at-risk patients. And then there's stage 0 up to stage 3. Stage 0 is a classification where there is no evidence of necrotic bone, but there are some non-specific clinical findings or even some radiographic changes and symptoms in this patient. But this is a very difficult stage to diagnose because there is no overt necrotic bone that is visible. Stage 1 is exposed and necrotic bone, and stage 3, that's a severe form of MRONJ, where you may end up with pathologic fracture, oroentral or oronasal communication, and osteolytic changes extending to the inferior border of the mandible. And as I said, so even though this is greater than 8 weeks, it's still there in the literature, but there's some rethinking of why do you need to wait for that period if the other criteria are there for the diagnosis of MRONJ. So what are some of the risk factors of developing MRONJ? One is the antiresorptive, the type of your antiresorptive medication that you take. So we know that the incidence is higher in IV bisphosphonates compared to your anti-angiogenics, which are higher than your oral bisphosphonate. So the risk of developing MRONJ is much lower in oral bisphosphonate. The other factor is your duration of the medication involved. And this is in terms of the cumulative dose. So it's not so much you having had this therapy, but it's more cumulative. How long have you had this medication, especially in your nitrogen-containing bisphosphonates? And dental alveolar surgery is considered as the most common risk factor for development of MRONJ, and I'll get back to that just now. And also the presence of infection, as we spoke about that study by Risto, that acidification in the oral cavity increases the chances of developing MRONJ. And some of the aggravating factors or the factors that may increase the risk of developing MRONJ, as we know in COVID as well, things such as smoking, obesity, steroid treatment, and the presence of periodontal diseases. So the presence of these conditions may exacerbate the risk of developing MRONJ. Now, in the past couple of years, dental extraction on its own was regarded as a significant risk factor for development of MRONJ. But now we know that every extraction, even patients that have been on bisphosphonates for a long period of time, does not necessarily translate into MRONJ. So the thinking at the moment is that much more than extraction, the presence of suppuration or infection is a significant risk factor in the development of MRONJ. So extraction, although it carries a risk with it, but more important than that is the presence of infection in the oral cavity. Now, the other thing that's of interest about MRONJ is that we know that there are children that are taking bisphosphonates for osteogenesis imperfecta. But an enigma in this situation is the fact that children taking bisphosphonates never develop MRONJ. Now, it's unclear in the literature as to why children are not susceptible to developing this osteonecrosis of the jaws, even though they are taking this bisphosphonate. So, for example, a systemic review by Palmer also confirmed that nothing has been reported in children in terms of developing MRONJ. So there's some speculation. Other people think that maybe the dosages of bisphosphonates in this kit is too low, but we're not sure. That's all speculative at the moment. But what we know as of now is that kids or children do not develop MRONJ. A major risk factor for development of MRONJ is things such as dental implants. The study by Pichardo shows that peri-implantitis around previously placed implants and insertion of dental implants are risk factors for development of MRONJ. So obviously it does not necessarily say that in patients that have implants, they will end up developing MRONJ. But the risk is increased in an environment where there is peri-implantitis. Now, Another study has shown that use of anti-resorptive medication causes osteonecrosis in patients with implants that have been subjected to functional loading. So I think we just need to be aware that patients who are taking bisphosphonates, particularly the oral bisphosphonate with implants, the risk is slightly increased of them developing MRONJ. What are some of the presenting signs and symptoms from MRONJ? As we saw, so you have your exposed bone. Sometimes there may be swelling or pain around the area. Post-extraction, obviously, there will be non-healing sockets. This is a picture that I got from one of the articles where, as you can see, this loaded implants, the extent of osteonecrosis in this situation. In terms of the investigations, nothing is really specific for MRONJ. So you know, you can have the same appearance in patients with osteomyelitis, osteoradionecrosis, destructive changes in the bone. So although there may be high sensitivity, the specificity in this situation, it's very low. So let's have a look at one of the cases that we saw a couple of years. This is a 59-year-old patient. She had presented with pain with exposed bone, a history of multiple myeloma, and she has been on treatment for with IV bisphosphonates. And the patient also reported having had multiple surgery in her lower limbs. So if you look at this panelips, you can see the osteolytic changes in the mandible, but more significantly, there's a pathologic fracture in this case, and the same applies onto that other X-ray. So history of multiple myeloma, bisphosphonates treatment IV. As you can see, the destructive changes on the CT scan, and that's the surgery that she's had on her lower limbs. And in that case, I mean, by virtue of the extent of the lesion, so we had to do resection onto bleeding bone and replace that with a recon plate. You can see here 3 years later, where there's complete mucosal coverage, no exposed bone at all, and extraorally. That's how she appeared after 3 years. So some of these cases, the treatment has to be aggressive in order to get rid of your necrotic bone. Another case, a 39-year-old female patient, she came complaining of exposed bone in her mouth. This patient had concurrent craniofacial fibrous dysplasia. When she presented, she just had an extraction done by a dentist. The history was significant for breast CA, and she had mastectomy, and she also been on treatment with IV bisphosphonate. So that's a presentation that she came, as you can see, retained road. So she had an extraction that was done in the first quadrant, also multiple carious teeth, as you can see. And that's a clinical presentation. So when she consulted the dentist, she says, you know, I'm a patient who's on I've had bisphosphonates, but she presented with a mobile tooth, and an extraction was subsequently done, and she presented with non-healing socket, which subsequently progressed into basically exposed bone in the entire second quadrant. She presented during the lockdown to one of my friends, and she hasn't had any treatment as yet, and she presented again last week. The necrosis has moved across almost into the second quadrant, and you can see the concurrent infection and the retained roots on the other side. Now, there's still some plans of how you're going to treat this patient, but there's no way you can preserve the maxilla in cases such as this. So a comprehensive treatment plan, which will be a multidisciplinary approach, is being planned for her. So what are some of the general treatment strategies for MRONJ? So if the secondary infection, antibiotic therapy, obviously guided by your culture, has to be implemented. Although I must state that the presence of necrotic bone itself does not necessarily translate to an indication for use of antibiotics. So if there's no secondary infection, there's no real need for this patient to be on long-term antibiotics. So things such as mouthwashes and debridement of the involved areas are important. Okay. Just keeping the areas nice and clean to prevent a secondary infection, and obviously follow up of this patient. So some people say that in some cases you may need to delay surgery up until stage 3. But the idea is about doing all we can as dental practitioners to prevent any irritating necrotic bone intraorally. So if you do an extraction, for example, you should raise a flap, make sure that you smooth the bony edges, mobilize your flap, and achieve your primary tension-free closure. So in most cases, extraction is not really contraindicated, provided you do adequate measures to prevent exacerbation of the disease. So there are 3 conditions that you may be presented with. One is patients who are on oral bisphosphonates, or patients who have CAs about to embark on bisphosphonates, or patients who are already taking bisphosphonates. So what are some of the prevention strategies for patients who are on oral bisphosphonates? So as we said, the risk is low, but it's not 0. So the risk of MRONJ increases with the number of years that you've been exposed. And in the presence of other conditions, the risk may be accelerated. As we said earlier on, the risk of MRONJ in this patient taking oral bisphosphonates is low, and dental alveolar surgery is thus not contraindicated, especially in patients that have had exposure of bisphosphonates for less than 4 years. Now, there's also a consideration for a drug holiday in patients on oral bisphosphonates, where the patient will cease taking the medication and restart after a period of about 6 months. So especially in patients that have had exposure for greater than 4 years, or in patients with less than exposure but have chronic use of steroids, are also taking angiogenics. Okay. So presently, there isn't sufficient data to support or refute the fact that drug holiday alters the risk of MRONJ. But the recommendation seems to be prudent. And we do not have enough data on the risk associated with denosumab or antiangiogenesis in terms of is drug holiday of any value in these patients. And one consideration could be the use of bone turnover markers in terms of establishing whether there's a risk or not. I'll come back to bone turnover markers just now. The other consideration is for patients who are about to commence treatment for cancer using bisphosphonate. So in this patient, the suggestion is that if possible or where possible, you could delay the initiation of your meds up until you have optimized the oral hygiene status of the patient. Obviously, it's not always possible. That's general recommendation, because sometimes you may need to initiate these meds quite urgently. What about patients who are on IV bisphosphonates? The recurring theme again is good oral hygiene. Okay. If you can avoid invasive procedures, and obviously informed consent has to be given to this patient. The general approach is that drug holiday is not recommended for patients on cancer treatment, given their clinical benefit. Some studies have suggested that they may be of value, but at the risk of patients ending up with metastasis. And there's a question mark again of using bone-10 over markers. So obviously you want to do all you can to make sure that there's nothing intraorally that may risk patient developing MRONJ. So in terms of bone markers, one of the markers that have been used to predict the risk of MRONJ is your CTX, C-telopeptide of collagen type 1. So this is a byproduct of degradation of collagen type 1, which occurs following bone resorption. Now, other bone markers that have been suggested includes your parathyroid hormone, but there hasn't been any correlation established as to the risk of the correlation between the level of PTH and MRONJ. Also, your alkaline phosphatase, no correlation has been established. But CTX is one of those agents that have been recognized as a possible biomarker or indicator of whether the patient is more likely to develop MRONJ or not. Now, Robert Marks, in a case series of about 30 patients, suggested that your CTX levels of less than 100 puts you at a very high risk of developing MRONJ. But once again, these are not randomized clinical trials. This is a case series that Robert Marks suggested from that a CTX of 100 picograms per millimeter may put you at a higher risk of developing MRONJ. But a recent systemic study has shown that the use of CTX level to diagnose the risk of MRONJ is not clinically justifiable or recommended routinely. So although it may give you some kind of a guide, but in terms of its routine usage, there is no scientifically or clinically validated reasons for its usage. So even though it's not a definitive predictor of the development of MRONJ, it may be used as an adjuvant marker in risk assessment of MRONJ in this patient. So the question that we addressed earlier of why the jaws and the jaws of the study by Risto suggested that the pH in the oral cavity is a significant contributor, but also that your bisphosphonates are stored in your bone matrix and they may be reactivated in an acidic environment. So in terms of the controversy associated with MRONJ, there's a suggestion that it may be refractory to debridement And in some cases, surgery may be counterproductive. Is there any role for hyperbaric oxygen? And any role for autogenous platelet concentrates? And then the question mark of the role of teriparatide or recombinant PTA. Now, there has been quite a number of reports lately of the role of autologous platelet concentrates in the treatment of many conditions in the oral cavity, including MRONJ. The debate ranges about do they have the ability to improve healing and to promote tissue regeneration? Now, at one stage, I thought, there's so much talk about PRF and PRP. I thought they were kind of, treatments looking for a disease. But of late, there's some evidence that is starting to show that maybe this autologous platelet concept may have a role in promoting healing in some of the oral conditions that we see, like MRONJ. For example, you can have a PRF membrane, so post-debridement, you can use it to cover the defect and close the mucoperiodontal flap over it. So although there is no concrete evidence of the role of PRF or platelet concentrates in the treatment of MRONJ, some preliminary evidence suggests that they may play a role in this process. But systemic reviews by Lorenzo, for example, have shown that there isn't sufficient evidence to run with this platelet concentrate as treatment modalities for MRONJ. The other suggested treatment modality is recombinant parathyroid hormone, PTH, which is called teriparatide. And it is thought that it stimulates bone formation and it has great effect on wounded bone. So it acts by inhibiting a sclerostin. So there's a lot of studies that are being done on assess the efficacy or the outcome of teriparatide in MRONJ patients. But once again, there's low-level evidence. So although it is suggestive that they may play a role, but there's no high-level evidence from randomized clinical trials to suggest that they do have a role. Drug holiday, we spoke about it, that it may play a role in decreasing the risk. But I think the important thing about drug holiday is that it shouldn't be taken in by a dental practitioner or specialist in isolation. There has to be consultation with the oncologist, because especially the IV bisphosphonates, they are there to prevent bony metastasis, which may have significant consequences on this patient. Now, Eric Carlson said his approach is to have an aggressive approach in terms of treating these patients with MRONJ. So if there's dead tissue, it cannot be resurrected. If exposed necrotic bone is there, you need to be aggressive and remove that necrotic bone. According to him, resection, whether it's marginal or segmental resection, it's always predictable in terms of the outcome. So there's a suggestion at the moment that early surgical treatment may prevent disease progression. And this will be some of the indication for resection in this MRONJ patient. So MRONJ is a recently described epidemic that only affects the jaws. And we think that the acidification in the oral cavity may have something to do with it. The risk of MRONJ is much higher in patients on IV bisphosphonates. It's not reported in children receiving bisphosphonates for osteogenesis imperfecta. Is it because the dosage is too low? We don't know at the moment. We also know that extraction, periodontal disease, and peri-implantitis may be the main trigger from MRONJ. But the presence of infection in the mouth can increase the risk to much higher level. The role of drug holiday in either osteoporotic patients or cancer patients on IV bisphosphonates. So in osteoporotic patients, you can get away with your drug holiday, but in cancer-related conditions, there's a question mark of this drug holiday. Now, this is one of the conditions where the dental profession plays a critical role in the prevention and management of MRONJ. It's a condition that we can speak with authority because it only affects the jaw. But whatever we do has to be done in consultation with oncologists. So some of the future research that needs to be undertaken about MRONJ is, the role of surgical and non-surgical management of this condition, any role for modification of this antiresorptive medication. These children on osteogenesis imperfecta that are taking bisphosphonate, what will happen to them long term? When they become adults, are they going to become are they going to be in a much riskier position to develop MRONJ or not? We don't know at the moment. And then is there any role for teriparatide or other anabolic agents? We're also not sure. We still need to do a lot of randomized clinical trials to establish high-level evidence of the use of this agent. And the recommendation should not be based on case reports. Now, the approach to managing patients with MRONJ, it's not a one-man show. It's a multidisciplinary approach. So this condition, you need to manage it with oncologists. For complex cases, involve plastic surgeons. So together, we can do more as opposed to running this show alone. Thank you very much.
Thank you, Prof, for that informative and interesting presentation. It was quite a bit of information you shared, which I think is quite valuable for our dental profession. Just a reminder to all the participants, please use the question and answer tab for any further questions. Rather than raising your hand, we will address the questions that are stated in the question and answer section. Prof, there have been some questions that have already been answered by Dr. Boisvali. I will ask those questions as well. Between myself and Dr. Boisvali, we'll go through the questions with you. Prof, can we proceed with questions?
Yes.
All right. The first question we have is from Dr. Veli. How does one differentiate between the initial stages of osteonecrosis and a dry socket?
So, I mean, remember the diagnostic criteria for MRONJ is a history of usage of antiresorptive medication greater than 8 weeks. So if it's at an early stage, like post-extraction, I think you're going to have to do all you can to treat the non-healing socket as a dry socket. Because, the period that needs to be observed is a period of 8 weeks. So if there's exposed necrotic bone for that period greater than 8 weeks, then your diagnosis of MRONJ will be made. But I will treat that as a dry socket, for example.
Okay. Another question from another attendee, anonymous. I have a new patient who I suspect has ORN. For those who are not aware, ORN is an osteoradionecrosis. He had extractions done elsewhere, neglected to tell me his medical history multiple times. I have from his GP because the dry sockets had not healed for 4 weeks with pus training. I've referred him to specialists who've told me to refer to Tux or Wirtz. Who can manage him? What can I manage him with in the meantime? He's got a very complicated medical history, which he refuses to disclose when he's coming to practice days. The further addition to that question is that there was a diagnosis of laryngeal carcinoma 3 years ago for which the patient did undergo radiation therapy. Any advice for our attendee, Prof?
So, I mean, funny enough, one of the treatment regimen for OR and osteoradionecrosis is clodronate, which is a bisphosphonate. But for a patient described as such, I will consider using pentoxifylline as an initial management strategy for this patient. It appears like the patient has got ORN in view of the history that has been given. So we cannot ignore the history the patient is giving, but for now, our minimal debridement and pentoxifylline for that patient.
Okay. The next question is from Dr. Boertha. Do you need to record all 3 diagnostic criteria for positive MRONJ diagnosis?
So that's a very good question in terms of your diagnostic approach. So if you were to follow the standard or the recommended diagnostic criteria, so there has to be a history of usage of antiresorptive medication, either bisphosphonates or denosumab or antiangiogenic medication. That history has to be there. And the second one, exposed necrotic bone, and as I said, there's a question mark about the 8 weeks criteria. And the other one is no history of radiation treatment or any current or any metastatic disease. So those 3 are regarded as your absolute diagnostic criteria for MRONJ. So you need the presence of those 3. 8 weeks is debatable. Some people say less. Okay.
Okay. You mentioned in one of your slides that the use of hyperbaric oxygen is debatable and questionable and still a controversy. One of our questions from Dr. Raj Kumar, does hyperbaric oxygen therapy help in improving the vitality of bone?
So, hyperbaric oxygen, I'm trying to say how I can be diplomatic about answering this question. Personally, I feel that it's overrated. And there are no long-term randomized clinical studies that show its effectiveness, whether in patients with osteoradionecrosis or MRONJ, as we were speaking now. So remember that when Robert Marks suggested the usage of hyperbaric oxygen, so his assumption is that in irradiated tissues, you've got hypocellularity, hypoxia, and hypovascularity. So the aim of using HBO is try and reverse the hypoxia, which Robert Marks thought was the driving force for development of osteoradionecrosis. But there have been studies that have shown that, if you use placebos in patients that had minimal osteoradionecrosis and use HBO, there was no difference in the outcome in this patient. So hyperbaric oxygen, it's a very costly treatment mobility. But the results thereof are not guaranteed or at least established independently. So my threshold for using hyperbaric oxygen is very high. It's probably the last thing that I will use. So I would rather, for osteonecrosis, for example, I would rather use maybe pentoxifylline, minimal debridement, but hyperbaric oxygen, I think it hasn't been independently established that it has of any value in treating these conditions.
Okay. Then our next question again from an anonymous attendee. What precautions should be taken before doing extractions on patients with a history of bisphosphonate therapy? Is there a timeline in which it is safe to do extractions, or is the risk factor for ORN for life after use of bisphosphonates? Would it be advisable to rather refer these patients to MaxVac? I think I'm going to give them to you one at a time, Prof. What precautions should be taken before doing extractions on patients with a history of bisphosphonate therapy?
So as I said, that the recurring theme is an excellent oral hygiene, okay? So ensure that the oral hygiene is optimized in this patient, because the thinking these days is that extraction on its own, it's not an independent risk for developing, but extraction in the presence of infection kind of increases the risk of developing wrong. So I'll make sure that the oral hygiene is meticulously maintained. And as I said, if you do an extraction, see if you are able to get primary closure, smoothen off the rough bony edges, and tension-free primary closure. But if in doubt, I would, if I were a general dental practitioner, I will send the patient to a maxillofacial surgeon because they are in a better position to kind of raise a flap and ensure that there's alveolectomy and there's no exposed bone post-extraction. It sounds like we're marketing ourselves, but that's a reality, that if a maxillofacial surgeon handles these cases, it's much better than a condition that's handled by a general practitioner.
Okay, then in the same question, is there a timeline in which it is safe to do extractions, or is the risk factor for ORN for life after use of bisphosphonates?
So as I said, the half-life of this bisphosphate, for example, Zometa, it's 10 to 12 years. And some people say it's there till infinity. So if it's oral bisphosphonates, it's much lower risk. So you can continue with the extraction pretty safe. Whereas if it's IV medication, the risk is there in the lifespan of the patients, because the half-life is only 10 to 12 years. So for a patient on oral bisphosphonates, you can do a drug holiday for 2 to 3 months. After that period, do your extraction and then reinstitute the therapy after another 3 months or so. So on patients on oral bisphosphonates, it's much more predictable in terms of what we can do. But the IV ones, it's a bit tricky, because I certainly wouldn't recommend a drug holiday on my own without consulting the oncologist, given the benefits of this medication.
Okay, then the last part you have answered as part of your answer earlier, where the question was, would it be advisable to rather refer patients to MaxVac? Without
a doubt.
Okay. We've gotten a few messages of gratitude for your presentation as well, one of them from Dr. Fourie. The next question would be, what length of time is recommended to wait for healing of extraction sites in a patient taking bisphosphonates prior to making dentures, as traumatic dentures have been documented to cause exposure of non-healing bone?
So, I mean, as long as you've got full mucosal coverage, post-extraction, and maturation of the oral, the mucosa itself, I will go ahead. So, you know, once you have got full mucosal coverage, about a month or so, then I'll be comfortable to go ahead and make some dentures. But obviously, minimal irritation from those dentures. The ones that I used to make when I was a GP, I don't think they will survive MRONJ, you know? But they make them better these days.
All right, our next question is from Dr. Botha. Can MRONJ occur randomly, or does it have to occur after mucosal or alveolar disruption?
It can occur spontaneously. So you don't need a trauma or any kind of surgery as a trigger. It can happen spontaneously. Okay.
Next question from Dr. Clement. What types of pain control medication are you using, and what are recommended, and is the pain management therapy considered long-term, i.e. chronic, or is it treated by need?
So funny enough, these patients, even though they have exposed bone, they may not have significant pain in the, you know, so the bone is there, it's exposed, but the pain may not be that severe. And that's why the emphasis is on a meticulous oral hygiene. So your mouth rinses, fluoride treatment and the like. So the exposed bone itself does not necessarily correlate with high level of pain. Pain happens when there's a secondary infection. But if there's pain, you know, you still pain or Celebrex or Brufen or whatever, you know, depends on the level of pain that the patient has. But I think the key point is to understand that even though you've got exposed bone, it may not necessarily translate into pain. But secondly, exposed bone itself does not warrant usage of antibiotics. So I'm kind of concerned by the haphazard or indiscriminate use of antibiotics by some members in our profession, you know. So if bone is exposed, to say, does not mean antibiotics. So remember that the more antibiotics we use, especially the broad spectrum antibiotics, the higher the risk of creating an environment where resistance is established in relation to those antibiotics. So we need to practice antibiotics stewardship. And that's why I said that if there's a need for antibiotics, it has to be culture-directed antibiotic therapy. But when bone is exposed, it does not call for initiation of antibiotics. Mouthwashes are adequate to control this. Yeah.
All right, then we have a question from, or suggestion from Dr. Anirudh, where he says, at the start of your talk, you mentioned a possible negligence risk. Could you please be so kind as to advise on considerations to prevent any medical legal risk for the GP practitioner when treating acute pain and sepsis in patients at risk of MRONJ who do not need referral to a specialist surgeon?
Thank you, Sunil, for the question. I think the point that I was making was that, number one, you ignore the patient's history at your peril. Number two, you need to document what the patient is saying to you. So what I'm saying, what I was saying is that if the patient gives you a history, for example, that I'm taking bisphosphonates, but they present with a mobile tooth, and you're not sure about the relationship between bisphosphonates and what may happen to the patient. Rather abort the procedure, either refer the patient to people who are appropriately trained to handle those cases, or consult the physician who's treating the patient. But to go ahead and ignore that history and do the extraction and risk the patient of developing MRONJ, I think it's kind of negligence. You know, they say that there's a difference between a complication and negligence. The complication is something that you have spoken to the patient about you have warned the patient. Whereas negligence, it's something that you haven't informed the patient, probably because you don't know. So I think there is more responsibility on clinicians to establish the risks associated with the treatment that they are undertaking, particularly in a patient that is on long-term medication for whatever reason. So we cannot ignore what the patient is taking. We have to treat patients holistically. You know, it's not about 8201 or 8937. It's about a holistic approach to patient care. So document what you're doing, get a good history. I remember one time I was taking history on a patient. She was taking tons and tons of medication. I mean, at one stage she said to me, "Isn't there enough medication?" You know, but get as much history as you can. It's always better to over-document than under-document these cases.
All right, I'm going to combine two questions, similar question. It's from an anonymous attendee and then from Dr. Jose. Case studies have been reported in the recent literature where MRONJ due to IV bisphosphonates were treated with adjunctive pentoxifylline and tocopherol with some success. What is your opinion on the use of pentoxifylline and tocopherol?
So what we know is that pentoxifylline and tocopherol, they are antioxidants. So they're used mainly to scavenge your free radicals, but they're also vasodilators. Okay? And we know that free radicals play a critical role in the pathogenesis or development of osteonecrosis. But in this case, even though we don't have a clearer picture of what is behind MRONJ, as far as I know at the moment, the role of free radicals in development of MRONJ hasn't been established. So pentoxifylline and the tocopherol, the antioxidants, to do with free radicals. Whilst we may not have all the information, we know that there's interference with your bone remodeling. So they affect some kind of resorption and antiangiogenesis and stuff like that. So I think they may very well be documented, but you know, based on case reports, it's very difficult to come up with concrete protocols because case reports depend on who's doing them and what other conditions, for example, or medication the patient is taking, the age, what kind of bisphosphonates they're taking, are they obese, and stuff like that. So the best protocol are established based on randomized clinical studies, prospective studies. But I guess there's no harm in giving, for example, pentoxifylline, although you have to be careful in patients who are hypertensive because they're vasodilated.
Okay. Our next question from Dr. Etzman. Is there any emphasis to recommend to the practitioners who prescribe bisphosphonates to, where possible, ensure a healthy oral environment before the start of bisphosphonate treatments?
There's no doubt about that. Huh? So I'm assuming that we know the ones who are prescribing the bisphosphonates, be it for osteoporosis or for malignant conditions.
My understanding is that the question is, are we emphasizing to people prescribing bisphosphonates about the need to ensure a healthy environment before starting those bisphosphonates?
Without a doubt. That's why I said the recurring theme is an excellent oral hygiene and prevention of infection. Because if your oral hygiene it's improved, then your risk of developing MRONJ, we think it's decreased already. So there's no question about that. That meticulous oral hygiene is a significant requirement in terms of decreasing the risk.
All right. I'm going to ask Dr. Boisvali, my co-host, to ask some further questions. Dr. Boisvali, can I hand over to you?
Thanks very much, Dr. Hira. And to thank you, Professor Rikhotso, for an excellent presentation. I'd just like to expand on the use of hyperbaric oxygen with osteoradionecrosis. And I completely agree with you that once the bone is dead, it's dead, and there's no ways that you're going to get it to become alive again with hyperbaric oxygen. Do you think that there could be a role in maybe increasing soft tissue angiogenesis with adjunctive hyperbaric in a severe case or not? And now I think we're mainly talking about osteoradionecrosis.
So, I mean, I agree with you, Greg, that you can't resurrect dead tissue. All right, unless you go to some prophet in Pretoria, maybe that can happen. But as we know scientifically that we don't think we can resurrect dead tissue. And so HBO is thought to increase neovascularization, so angiogenesis. So for that reason, I will say, as long as there is no harm to the patient in terms of HBO itself, but an attempt to increase neovascularization, I think that will be a welcome intervention. So the question is, does it do that? And that's a question for a discussion for another day. But it is thought that HBO increases angiogenesis. Obviously, you're giving more oxygenation in the area. It's thought that it may have some antimicrobial activities and may also be anti-osteoclastic. So, yeah. So, but for reasons such as increasing neovascularization in the tissue, I will probably say, yeah, go ahead with HBO, but it's very expensive.
No, it's extremely expensive. Yeah, a lot of the osteoporosis specialists are moving away from prescribing oral bisphosphonates to using a drug called intravenous aclaster. It seems that they prescribe an annual intravenous dose spread over 3 to 5 years. Any precautions that you can advise our audience with regards to patients who come in and require extractions, or patients who come in and ask about, can you do an implant in me?
Thanks, Greg. So, yeah, instead of patients taking daily or weekly anti-osteoporotic medication like Posterior, for example. Now there's a move for patients to do IV meds once or twice or thrice a year. As we know it, if you use IV, the risk is a little bit higher. But the important thing is that it's more the cumulative dose as opposed to once or twice in a year dose. So it's the accumulative effect of bisphosphonates in the body. But my understanding, as I said, Greg, earlier on, my understanding is that the use of this medication does not necessarily preclude surgical intervention.
Yeah, I agree.
All the necessary precautions need to be taken when undertaking surgical procedures. For example, tension-free closure and whatever, not. But the key is that oral hygiene that we're talking about. That is the critical outcome.
Yeah, I agree with you. And how we know that is that I'm work in a multidisciplinary head and neck oncology team, and the oral care after radiation is significantly improved, and the risk of local osteitis or osteonecrosis due to radiation is significantly reduced if you get the patient to see the oral hygienist or even the dentist themselves doing the scale and polish on the patient 4 or 5 times a year.
Yeah. So I think the role of be it the general dental practitioner or oral hygienist, it's critical in terms of maintaining good oral hygiene on these patients. And this is, I think, where we have a bit more authority when we speak to the oncologist and stuff like that. But let's get the patient infection-free, ensure that they've got good oral hygiene.
Yeah, I agree with you. Just to ask you about your protocols with regards to osteonecrosis and pentoxifline and vitamin E. There's an article written by Andrew Lyons in the British MaxFac Journal, I think February 2016, that says that there is some benefit being found with the use of pentoxifline in MRONJ. Any experience?
Look, personally, I don't have any experience. As I said, pentoxifline and vitamin E, they scavenge the free radicals. So probably they won't have any. They may not aggravate the condition. But personally, I don't have any experience. So I would think that maybe it's not a bad thing to consider using them in terms of clearing those free radicals. And they are also vasodilators, as I said.
Yeah, I think so. There's a question from both yours and my teacher, Professor Russell Lurie, and I welcome you, Prof. Lurie, to the presentation, and thank you so much for your guidance and teaching of both Ephraim and myself over the years. Prof asks, over the last 5 years, has there been any protocol for managing the systemically compromised patient who needs a dental clearance of a few perio-involved teeth, who has comorbidity of the diabetes and high blood pressure?
Okay, maybe to begin with that, Prof. Lurie is one of the giants on whose shoulders I've ridden for many years. if I may take this opportunity to thank him and say, Prof, we are grateful for your contribution to the profession, not only the Society of Maxillofacial and Oral Surgeons, but the profession as a whole. So I think I'm not aware of any change in the protocol, save for ensuring that either both diabetes and the hypertension are well controlled. But I think diabetic patients are obviously more at risk of complications, as we know during this COVID time, that if, for example, the comorbidity itself, like diabetes or even hypertension, is not well controlled, the risks are much higher. So ensuring that there's adequate control of the comorbidity involved, I think if it's all well controlled, there shouldn't be any change in the management approach to any other patient like you and me. But the key is to control those conditions, because if they're not well controlled, then the risks of complicating much higher.
Well, if there aren't any further pressing questions, just as a take-home statement to the profession, MRONJ is a reasonably new condition, and I think we're learning all the time, especially with osteoporosis on the one hand and oncology on the other hand, using IV bisphosphonates. And do you think there's a difference in the disease pattern between someone who uses IV bisphosphonate for osteoporosis and the disease pattern with breast cancer or multiple myeloma or prostate? A take-home message to the practitioners: what do you look for? What are the important things?
Look, definitely there's a difference between those, whether it's dealing with osteoporotic patients or patients who are on this treatment for cancerous conditions. So remember that if a patient ends up with metastasis because this medication was withheld, it's a life and death issue. That's why I wouldn't even venture into recommending drug holiday for these patients. Patients on bisphosphonates for cancer-related reasons. But in terms of osteoporotic patients, although I will still take the necessary precautions, but I'm kind of less concerned, or maybe that's not a proper word, but I'm less concerned about them deteriorating as opposed to patient taking cancer medication. So definitely for osteoporosis, risks there, but I'm much more concerned about patients on bisphosphonates or antiresorptive medication for malignant conditions. So that would be something that I would say we as dental practitioners need to be aware of patients on this medication.
There's a private communication between Sunil Anurith and I, and he wants me to please ask you, can you raise the off-label use of bisphosphonates for periodontitis? There is a Difficult study that recommended it. Any comments?
Off-label use of bisphosphonates for periodontitis. Yeah, I have no experience on that. All I know is that periodontitis puts you at a higher risk of developing MRONJ if you take in bisphosphonate.
Yes.
But I'm not sure about the vice versa relationship between the two.
Any further questions, Pravesh, or are we going to let Ephraim?
There are some questions which haven't been answered.
Okay.
We've reached our limit in terms of time. I can give it a further 5 minutes, and then anything that isn't answered, we'll send off to Prof for him to answer and respond to the people that have asked the question. So let's give it 5 minutes, and then we'll call it a day.
There's a question by Norman Clement, and he has posed a number of questions, but the one thing that I think is important is, how does smoking affect MRONJ?
Look, there are very few benefits of smoking.
Yeah, no, well, I agree there.
Yeah, but what we know is that smoking is a vasoconstrictor.
Yeah.
So obviously it affects your blood flow. So your healing capability, it's much more decreased if you're a smoker. So apart from the other risks associated with smoking, but we know from a healing point of view that it's a vasoconstrictor. So I think that's probably one of the ways that it contributes to MRONJ.
The other question that he asks is, do you think that blood pressure medication, i.e. ACE inhibitors and things like that, accelerate MRONJ of the jaw? And he didn't differentiate between oncology patients or osteoporosis patients, but do you think that ACE1 inhibitors and blood pressure have an effect on MRONJ in bisphosphonate use?
So I'm not aware of that relationship between ACE inhibitors and MRONJ. But what we do know is that the use of teriparatide, which is a recombinant PTH, that parathyroid hormone that we spoke about, it's not recommended on patients that are taking medications such as digoxin or certain antihypertensive medication. So there's limited use of teriparatide, but I'm not sure of hypertension or its medication on its own as a risk factor for developing MRONJ. I'm not aware of that.
Anything that you'd like to, as a parting message, give to the dental profession with regards to take-home message, what to look for, what to advise the patients, and when do you refer?
So I think maybe two things. One is that because MRONJ affects the jaws, it's an area that we can grow in the dental fraternity. And the more cases that we collect, it will put us in a position where we can speak more with authority. So it's not a bad thing to kind of, where possible, a national registry of these MRONJ cases. Because when we get those cases, we'll be able to develop better protocols on managing these conditions. And the second thing that I want to say is that when you refer a patient, it's not a sign of weakness. When you refer a patient to a capable person, what it demonstrates is that you care about the patient. So if you are unsure about what you're dealing with, there is no harm in referring a patient to somebody who may be in a better position to take care of a patient. So this approach that if I refer a patient, I'm going to lose the patient, or the referring dentist is going to lose confidence in me, I think we need to check it out of the window. So referral, it's something that you do out of love and care for the patient to someone who is in a better position to take care of the patient. So when a patient comes to you, it doesn't mean that you have to do everything that that patient requires, even if you're not in a position to handle that situation. You know, you don't have to do a full house kind of treatment on a patient. If you're unsure, refer the patient, and it shows that you care about the patient. That's my last one.
And I think that most probably the most important thing is oral hygiene. I think if you can maintain the patient's oral hygiene, or you can refer your patient to practitioners who can most probably do the maintenance better than you can, I think it's in the patient's benefit.
Yeah, agreed. That's a recurring theme of this talk, that let's optimize the oral hygiene of our patients, and the risk of them developing other complications is much lower.
Yeah, I'll agree with you. Well, thank you very much for a unbelievably informative lecture. I think this is something that should be ongoing in the profession with regards to information for our colleagues. We can learn from each other, we can share cases, and ultimately it's for the benefit of our patients. So from my side, I'm going to say thank you so much for sharing your expert knowledge with us. Please don't stop in your quest for success and sharing and teaching, and we look forward to MRONJ Part 2 in the near future. So I'm going to pass the baton over to Pravesh, and if there's anything else you'd like to ask.
Thank you, Dr. Professor Ali. Thank you, Prof, for the great presentation. I think we've reached our time limit. There are a few questions that haven't been answered, which we'll send off to Prof to be answered, so we can at least send a response to the attendees. There's been quite a few messages of gratitude for Prof. A reminder to everyone who attended of our upcoming webinars on the 20th of October, 22nd of October, 27th of October, and 29th of October. Thank you once again, everyone, and good night.
Thank you.
Thank you.